No. Okay. This meeting is being recorded. Okay. All right. I think I got it now. Okay. All righty. Back to that. Sorry, Heather. Wanted to do it back to full screen. Hold on. Technological issues. Okay. Now I'll go back a slide. Okay. So, autism prevalence has increased 317% since 2000. So the most recent numbers that came out, oh, I don't think I finished the slide, sorry. And so I also work with people with autism and families with autism in the clinical setting. I have done ABA, social skills, been a school aide, been a one-on-one aide, and a babysitter. So I have a lot of different experiences when it comes to autism. Autism prevalence has increased 317%. You look at from 1970 when it was 1 in 10,000. My brother was born in 1990, and so it was about 1 in 5,000. By 95, it was 1 in 1,000, and now it's 1 in 36 that they just recently reported. And actually in California, I believe the numbers are 1 in 29. It's higher in California. And I just read this morning that 4.5% of the population in California have autism. So we have a big population here, so that's a big number. We're not really talking about why it's going up. Of course, I have my ideas of why, but basically at this point, we're just we just continue to see the numbers go up and more families affected. So the outline, I'm going to go a little bit over some terms that have to do with autism. The DSM criteria, I'm not sure if you guys are talking about the DSM, but I will go through all the criteria in how you actually get diagnosed with autism, comorbidities, other deficits, some clinical impressions from private practice, and then some treatments. Okay, hopefully we're still doing good. Okay. Here are some just FYI things that I like to start off with just to give you some ideas. So one really important quote when it comes to autism, especially when you're thinking about the hospital setting where you won't necessarily see people every single day, it's important to remember that when you've met one person with autism, you've met one person. So unlike other disorders where you can lump some things together, a lot of people with autism are very different. So my son and my brother are opposite in what their needs are, complete opposite, so much so that they trigger each other. So we'll talk a little bit more about that, but that's a really important consideration. Autism is not a processing error, it's a different operating system. So we have done Temple Grandin, who's one of the major speakers and advocates for autism, has done many brain scans. They're really fascinating if you ever wanted to look them up. And you see different areas of her brain that are smaller or changed or different in relation to autism. So we're talking about a different brain, a different way of viewing the world. And then I find it really important to use person first language. So what that means is that we say that my son has autism, because he also has red hair and he also has green eyes and he also has a funny personality. He has a lot of things. And when you say my son is autistic, to me, that tells you everything about him. And it doesn't. He has lots of other things about him. Same with my brother. So person first language is utilizing that I have a child with autism, also with a lot, like I said, green eyes, other things. So it's just a way to kind of make sure that you're being mindful of a really hard process people are already going through. Okay, so here are some common autism terms. I really have no idea what you know and don't know, so I just go over them, each of them quickly. So stimming is a big one with autism. That's hand flapping, stereotypical behaviors, like flapping in front of your face, hand flapping in general. Austin likes to do a or in front of his face. And these are behaviors that they're utilized to help calm their body down. And echolalia is repeating a phrase. So you say, what do you want for dinner? And he says, for dinner, or want for dinner. Or a lot of echolalia comes from shows. So, but the basic thing is not reciprocal language. It is echoing what the other person's saying. GFCF is gluten-free and dairy, or casein-free, which is dairy-free. And those are common inflammatory foods. And a lot of families choose to have their child be gluten dairy-free so that we can reduce inflammation in the bodies that are already pretty inflamed. IEP is the individualized education plan. And in working with somebody, this is going to give a lot of insight and knowledge about them. So we just recently did my son's IEP. Every 3 years, you do what's called a triannual IEP, where they do a lot of testing. They reassess to make sure that you are eligible for special ed, and they do testing to see present levels. And so if somebody were to just read my son's IEP before working with them, you'd be able to see a lot of where he is. They're often really big documents, but sometimes if you're working with someone in a setting, they're helpful to see and to read. Inclusion and least restrictive environment. So least restrictive environment is a term that it comes from the Individualized with Disabilities Education Act. And it's a big law that's put into place for trying to have rights for people with disabilities. So you have to assess the student and put them in the environment that is the least restrictive. So my son is in a mod severe classroom, which is basically it can only have 10 kids in the classroom, and it has about a 2-to-1 ratio of adults to kids. Right now, he only has 7. And that's the least restrictive environment for him now. But for some kids, that would be too restrictive. And so then you have mild, moderate, and then you have general ed. And they can do a lot of things where they pull the child out for one portion of general ed and put them in. So if you're really good at math, you could be pulled out for math and put into a general ed classroom, because that's going to be the least restrictive environment, and you get more opportunities to be included in other kids. Eloping is a term for our kids that run. They usually unsafely run away and have, and they can end up in a scary situation, like across the middle of the street, or in some kind of dangerous situation. Or one time, my son, who's not a big eloper, but he ran across our street into our neighbor's garage, into their house, and was sitting on their couch by the time I got there. So we have to have like locks on our doors and things like that to make sure he doesn't run or leave. Joint attention. So this is one of the things that they look for in diagnosing younger kids. So when working in pediatrics, this would be something we would be looking for. And so this is basically the idea of, hey, Heather, look at the sky, and that the two of us would look together and we would see that. And so kids with autism tend to not engage in joint attention behaviors, and that's a big warning sign. So something where you're like in a social reciprocity type way. PECs are picture communication systems. And one of the things that they're using now a lot more is called an AAC, which is an audio communication device. I don't know what that, I always forget what the A and the A stand for, but it's like an iPad where they have PECs on there, and the children are able to navigate it to ask her what they need. But PECs are basically like picture exchange communication systems. So they're used on in schools and visual schedules. And they're something that can be really helpful because these kids like to know what's happening and like to have a routine. So let's say you're going to go to the doctor, and it's like, we're going to wait in the waiting room, then they're going to call our name, and then we're going to walk into the room, and then you're going to they're going to look at your arm, and so you can give them a visual picture of and a schedule of like what's going to happen. Pica, this is one that you might come across too, because it's the eating of non-food items, and this goes a lot with autism. One of my friends had to take her daughter to the urgent care because she swallowed a penny. Austin likes to eat a lot of non-food items. He eats cardboard, crayons, the eraser of pencils, paper, sand, Play-Doh. And so we really have to monitor having those things around, because what goes in must also come out. And, the paper towel kind of gets wrapped in all of that. And I can't imagine what it's doing on the inside. So it can be kind of scary if they will eat things like pennies or things like that. Scripting. So this is a lot of kids with autism talk through the shows or the movies that they watch, because stimming can include watching the same segment of a movie over and over and over and over again. Sometimes they communicate that way, where they're like, come on, let's go, or something like that. But it's really, they're talking from a show, and it sounds like that they're giving that. So we have to recognize which part is scripting. Transitions tend to be really difficult for kids with autism. My same friend who had to take her daughter in, when they were doing an x-ray, she was screaming, so they have to go from the waiting room to the room to the x-ray, and screaming. She has to be held down. So in general, in school, we go from preferred to non-preferred activities, and the transitioning is really hard, and that can have a lot of meltdowns, which are loud outbursts that are inappropriate. My son will throw himself to the ground. He will hit his head on the ground. He will roll his body around, be very big and dramatic and over the top, especially for an almost 9-year-old. And then a sensory diet is what they give you, what you're given in OT to kind of work on some of the sensory processing issues that our kids might have. Okay. Here he is. Here's my sweet guy. So I'd like you to meet Austin. He is 8 years old. He'll be 9 in August. He's my oldest child. He's finishing 2nd grade. And like I said, he's in a mod severe classroom, which is a really great fit for him. He also has a one-on-one aid that's called a TSNA, which is a temporary special needs assistant or aid. And he has that because of some of his behaviors and needing extra support one-on-one that, some of the other kids don't need. So he just got reassessed. They gave him the aid. And so he has that in the classroom with him. Okay, so I have some videos that kind of show Austin's regression and kind of see, because he was a typically developing baby. Met all his milestones, was talking, mama, dad, ball. And then we slowly saw a regression in him between 18 and 31 months. So I'm going to play each of the videos just to give you a little sample of my sweetie. And where's your belly? Okay, that's one of my favorite videos of him. Here's another one, 18 months.
What does the dog say? Good job. What does a duck say? What does a duck say? Quack, quack. What does a cow say?
So you can see he's really engaged. As soon as I ask him something, he's responding. Even if the sounds aren't perfect, we look for that reciprocity in social engagement. And so I ask him a question, he answers. I ask, he answers. So this is 23 months, so 5 months later.
Look, kiss.
Now he doesn't even know that I'm there, and he's really focused on what he wants to do, and he didn't invite me into his world, and he's not answering the things that I'm saying. Coming back, not checking in, not looking, most toddlers are going to look back and be like, Mom, are you there? Are you good? Is everything
Austin.
okay? Doesn't
Austin.
answer to his name.
Blow mama a kiss. No.
Then finally comes up to me. And then this is the one, this last one, you can kind of see a little by 31 months. So at 2, he started speech therapy. So right after this video, but this is him about 31 months.
Hey. What are you doing back there?
Doesn't answer, doesn't look up. No eye contact with me.
Are you playing with your hair?
Trying to join into his world, doesn't respond. And as you can see, this video ended, but if you can see the difference in his face from 14 months to 31 months, it's like the light went off slowly, one to the other. And so, it wasn't like a light switch, but it was like we dimmed and now we're off.
And where's your belly?
Sorry, it's hard to know. Okay, so now we're going to go over the DSM criteria for autism. So you have to have a total of 6 or more items from sections 1, 2, and 3, with at least 2 from section 1 and 1 each from 2 or 3. So the first one is qualitative impairment in social interactions as manifested by at least 2 of the following. Marked impairment in the use of multi nonverbal behavior such as eye contact, gaze, facial expression, body posture, gestures to regulate social interaction. So if you looked in the last 2 videos, in the third one, he gave some eye contact towards the end, but he went running that way. He didn't care where I was. He didn't know I was videoing, like nothing was happening within that. And then in the last one, he doesn't even give me any eye contact, no social interaction. He doesn't change his body. He doesn't move his head. He does nothing to show me that we're having social interaction at all. So that is an example of what they're talking about there. Marked, failure to develop peer relationships appropriate to developmental level. So he had peer relationships. We were really involved in a mom's group, and he would play with them. But he slowly kind of started to pull away, and he would do his own thing and not necessarily check back in with what the other kids are doing, because parallel play is normal, where you're playing next to somebody, and next to the kids, and you guys are doing the same thing, but in your own way. But when this is different. It's like I am in my own world over here, and you guys are all playing over there, and there's a difference. And then lack of spontaneous seeking to share enjoyment or interests or achievements with other people. So this is kind of where joint attention comes into, and that is that it's, toddlers in general get really excited about little things, like I jumped, or look at the duck, or wow, a helicopter, these kinds of things get really excited. So at the park, there were probably dogs or people or something. And, at no point does he stop and be like, Mama, look, this is so exciting, right? And he still doesn't do that now. So if something's going on in there, he's not going to get my attention and be like, wow, look at this show. It's the coolest video I've ever seen at all. We don't have any of that social reciprocity when it comes to that. And then the last one is a social or emotional reciprocity. So my son's a big sensory seeker. And so one of the things that he does to now is that when I walk in the room, he will ask me what he calls foots, which is me taking my foot and like kind of massaging him with it. And when my husband walks in the room, he will ask for tickles. So he still, there's no social reciprocity. We are objects in order for him to fulfill the needs that he has. So that's still, where my other one like wants to do both things and shows me things, and we can kind of see the marked difference. Okay. Number 2, qualitative impairments in communication as manifested at least one of the following. So delay in or total lack of spoken language. So about 30% of people diagnosed with autism never speak. And so that's where the AAC devices coming in are really important and really big, because some kids are really, really good at allowing or finding what they want. They know what they want to say, but the language just isn't there. So there's impairment in the language center of the brain. There's a new documentary coming out. I think it's called Spellers. And it's about nonverbal kids utilizing these type of devices. I'm interested to watch it. In individuals with adequate speech, marked impairment in the ability to initiate or sustain a conversation with others. So it's called rote language. And this is what we still have today. So he just got home from school right now while I'm talking to you, and there's no conversation that happens with him where it's like, hey, how was your day? What did you do? Did you play with somebody? And if you did, you don't know if he's answering yes or no. So we ask those questions, but if he's like, I'm like, they sing a song and try to get who was there today. Let's say he says, Johnny was there today. It's like, I don't really know if Johnny was there today. We don't really know what he did. Some of my friends are like, it's so hard, like not knowing her favorite color or what he wants for dinner or things like that. So everything has to be presented, to them. And then they can kind of respond from there. And stereotyped or receptive use of a language or idiosyncratic language, so tone and pitch that are repetitive, flat, they have an odd tone about them. And I have some examples coming up. And then lack of varied, spontaneous make-believe play or social imaginative play that's appropriate to developmental level. So Austin really doesn't play. He still doesn't play till now. You're not going to find him, like going up and picking some toys and driving the cars around or doing imaginative play, like, oh, the bunny is hopping, or like, unless he's told to. The most thing he would play with on his own would be a kitchen, but not always appropriately, like slamming the doors or fumbling around. So even at age almost 9, he doesn't have play skills, and his play skills are probably very low. If you were to assess him, it would be like a 12-month level, let's say. And so these are really, there's obviously acceptance that it's come to that, but it is really hard to have that, that criteria and then really see where that deficit lies, where typical kids are playing with all kinds of things. They can play together, they're hide and seek and do, all of this. He doesn't engage in any play like that, not on a social level and not on even just riding a car around. So here are a couple samples of language from more recently. This was probably a month ago.
Yeah. Portuguese. Which ones?
It's E-R-O.
And that spells?
Hero. It's E-R.
So here he's asking for chicken letters, which are kind of like chicken dino, but they're letters because he has a fixation with letters. And so you can see that it's very rote. Daddy, I want chicken letters, H-E-R-O, right? I want 4 chicken letters. It's like very rote, very constructed language. And so, he doesn't say things like, gosh, I'm hungry, I need a snack. He just kind of gets obsessive with whatever he wants. And then let's say we were to have chicken letters and we didn't have H-E-R-O. No, thank you. No interest.
Merry Christmas, everyone.
Say, I miss you.
I miss you.
Hope you have a great day.
So in this one, you can kind of see the tone is an odd tone. It's a little cadenced, but he says Christmas. And then when I tell him, say, I miss you, he repeats, say, I miss you. So there isn't any social reciprocity there. And it's still like a very learned language and learned action that he's saying. Yeah, sorry. Okay, diagnostic criteria continued. Let's see. So number 3 is restrictive, repetitive, stereotyped patterns of behavior, interest, manifest level is one of the following, encompassing preoccupation with one or more stereotype and restrictive patterns of interest that is abnormal, either in intensity or focus. So the picture to the left is him probably when he's 4, and he would watch some kind of YouTube show at that time and memorize the pattern. If you see it, it says K-C-U-G-I-Y. And he would do multiple different patterns like that. And so he's always been focused on alphabet. The picture to the right, I'm not sure how you have it, but the picture with the puzzle, not in the bath, is him probably just a couple months ago. And we were at In-N-Out, and this puzzle is a fixation of his. We went on vacation over Christmas break. We had to bring the puzzle. We had my poor mother-in-law's anxiety was at a 10 that we were going to lose one of the puzzle pieces because we had to carry that thing around with us. So it was like we have Austin, Maverick, the puzzle, our purse. You know, the puzzle is a multi-level traveler. It's cardboard. And so he's had it out in the rain. He's had it by the pool on trips. And it's like fraying, but they don't make this one anymore. They have a different background and he's no thank you. No thank you on the puzzle. I mean, he will, as you see, he has like letters out of there. He will take some of those letters out that he's memorized some pattern and put them out for some unexplained amount of time. And then he will take them back and he will put them back and then get new letters. Sometimes it's 2, 3, 4, all different patterns. So in this case, you know, and it's hard because if we bring this to the park or something and another kid tries to touch it, he gets very upset. So we're very fixated on the letters and this puzzle. Super Y is a show that he's been watching. It's a preschool show. He's probably been watching it for 5 years, over and over and over and over on repeat. And then he cycles to a couple of other shows that are also preschool shows. One's called ABC Monsters. One's called ABC Galaxy. And these are just very letter focused shows, but not age appropriate. And he will not try a new show. So that would be pretty restricted. Apparent inflexibility, adherence to specific non-functional routines and rituals. He's very routine specific. He will ask me to go to certain places and we need to go there. I pick him up on Tuesdays and he picks a place. So the last couple of weeks he's picked TJ Maxx and we've gone there. Sprouts, Smart and Final, CVS. He picks somewhere that he wants to go and then he wants to do that. And even at school and during his IEP, that was a big focus, was him being so focused and so thrown off when a routine changes. Stereotyped and repetitive movements or mannerisms, hand or finger flapping, twisting, or complex body movements. He does the chest tapping. Excuse me. He does the chest tapping, the clapping in front of his face, and he likes to climb really high and like watch shows from the side of his eye. He likes to hang and swing and flip and do all kinds of things like that. But I would say mostly he taps on the ground, taps on him, likes to do different tapping is his big thing. And then fixation with parts of objects. I was trying to think about what he kind of does now. He doesn't do that as much now. But he would in the past, like doing light switches or opening and closing doors. When we first went to our diagnosis, that's what he did. He was opening and closing the door of the dollhouse, which was one of the areas where she, you know, recognized it was odd. Let's see. And then B is just delays in abnormal functioning, at least one of the following areas with the onset prior to 3 years old. So that's social interaction, language used as social communication, and symbolic or imaginative play. So we have all of those. Yeah, so when these kids are going to be diagnosed, they're diagnosing kids younger, even down to age 18 months. Where we're already able to see these types of behaviors that are happening. And so you're going to, you know, there's more and more within the medical setting, because usually at that age, before age 3, that's going to be the first step, either regional center or medical setting, starting at the pediatrician. So this is the MChat. They utilize this at the pediatrician. It's a diagnostic tool that's used as a preliminary assessment for these kids. And so let's see. Things like if you look at if you're point to something in the room, does your child look? So that's that joint attention. That's really important, along with, do they answer to their name? Have you ever thought they were deaf? Did the pretend play, climbing on things? Some kids like to do like movements like in front of their eyes, like sort of like odd like that. Do they point to something to ask for help? So you go through and you answer all of these and then they score them. And the scoring looks like So they have, you know, obviously just like assessments, they have some knows that you want to have where it doesn't have risk, but all the other ones. And so if you can have low, medium, or high risk in relation to autism, and then that kind of leads to like where we're going next. So you can see on the low risk, it's like if it's at a younger than 24 months, screen again. And then on high risk, if it's acceptable, you can bypass the follow-up and just refer them for early intervention and you know, more evaluations. So comorbidities that go along with autism are, oh yeah, so these are some of the things that we might experience together. You know, very few kids are just have autism. There's a lot of things that go along with the dysfunctioning body that they live in. So ADD, ADHD, meaning, you know, lacking focus, having a hard time getting them to settle and sit. When you start therapy, you know, they practice on them sitting for 5 seconds, 1 second, very low amounts of time. OCD, like some of the puzzle examples that I had, it's, you know, he really has OCD in like how things go. And if he puts out, you know, 4 letters to the puzzle and you knock it a little bit, he'll go back and fix it. Or let's say he has it standing up and 1 knocks over, he'll fix all of them. Or he does a puzzle and then he takes the puzzle out and like taps really weird and then puts it together. Like, so he has a lot of behaviors that are OCD based, and especially at different times of year. ODD, oppositional defiant disorder, because these kids have a lot of behaviors and aggression. Depression and anxiety. When I heard Temple Grandin speak at a conference that I was at, she said, one of the things she said in her like very rote, very autism language was that antidepressants saved her life. So based on the chemistry of the brain of a lot of these kids, you end up with depression, anxiety, and, you know, OCD, obsessive compulsive disorder is an anxiety based disorder. And it's a way we use to express anxiety in that way. Allergies. This is the big one that Austin has. And I truly believe that autism and allergies are one of the most unknown connections, because he doesn't ever sneeze. He doesn't ever cough, post-nasal drip, nothing that looks medical, but he has wild behaviors. So it's like the allergen comes in and it creates all this inflammation in his body. And he is screaming and yelling and upset, and like his behaviors are wildly out of control. And then with allergy medication and with, you know, Motrin, then he's able to calm himself back down. PANS and PANDAS are kind of the same. So PANS stands for pediatric autoimmune neuropsychiatric syndrome. And PANDAS is the same, but it is in relation specifically to the strep bacteria. And through testing and trial and error, we have found that our son is really sensitive to strep, and strep's in our normal flora. So if I'm talking to him and I'm a strep carrier and strep comes out and he gets that, he's going to have a huge reaction. It's kind of similar to like peanuts. So where you have that anaphylactic reaction, but his is all within his body. And so we are working on some, you know, getting him to regulate that a little bit better. And then same with gastrointestinal issues. Like 38% of these kids have SIBO. Even higher percentage of that have constipation issues, have, you know, a lot of kids get very blocked up. And just in general gut health issues. Sensory processing disorder. So people with sensory processing issues either have too much or too little stimulation through their senses. This is something that can be really important within like the hospital setting, because, you know, there's obviously a lot of sounds and lights and noises and people and things. And, you know, us typical adults sometimes have a hard time with that. And so, you know, you could only imagine if you're dysfunctionally processing sensory information, that can be really overwhelming for them. And sometimes when he's at OT, they just turn the lights off and kind of let him chill. And then recently, the last few nights, he's been falling asleep with his light on. It's like, I don't really know which one he likes, but that can be something to think about. So they they have difficulty integrating all the information. So like when you hear and see something at the same time, or person speaking, a dog barking, a baby crying, all out of sync, and it can be overwhelming. So our son is an under responder. So he needs a lot of sensory input. Like one of his favorite things is for me to sit on him. He calls it, that he calls squeeze. Yeah. So squeeze means I like sit like on his lap with all of my body weight. And then he goes, oh, more. And he's been doing this for a few years. He's a lot bigger now, but even when he was smaller, he would go underneath like a bean bag and want you to sit on it and squish him down. So he needs a ton of input. He likes like the massage gun, and he'll put it on his mouth, on his chest, like, and it's really hard. He loves being in the water. He likes to climb really, really high. And that's the other picture. That's, I probably come up to, this first, under this first pink line, and here he is way up there. And then the top picture is him looking at something really, really close, which is something he does. So he'll get really close to it, and so that he can see it. He can see it from a different view for himself. And then my brother, on the other hand, is hypersensitive. So he is a over responder. He doesn't like touches. He doesn't like loud noises. He always has shoes and socks, and he likes to be very, he's much more aversive to sensory needs, where Austin is almost always naked or in just his boxers. He never wears shoes. He likes to be cold. His favorite thing to do when is like cold, laying outside in a blanket or swimming in the rain. And so he really likes all that different input all the time. He needs it, even his food. So he only eats pretty much crunchy food. And in the past, he's eaten like spicy, crunchy food. Now it's salty, crunchy. So chips, bacon, pizza with no cheese, pretzels, like things that are very stimulating for his mouth. He doesn't eat anything cold or nothing soft except Nutella sometimes. Other sensory needs. So when you oral, you have a heightened sense of taste and smell. You need really strong flavors. Or spicy food in order to get feedback in your mouth. Tactile, he likes to be barefoot, like putty, clothes. He likes to play with beans and rice, but then he also eats a lot of those things. So it's a little harder for him to have tactile, like if he had putty or even when he plays with Play-Doh, he'll eat it. So we have to watch that. And like they have beans and rice at the, at his OT, but he will eat the rice like uncooked. Visual, looking things out of the side of the eye, looking really close up, preferring lights or bright colors. Auditory is like heightened sense of sounds. Loud sounds might hurt, or you might like them. Like he's a very loud person. Proprioceptive is where your body is in space. He does a lot of leaning in order to kind of gauge his environment. So if I lean on you, I kind of understand where the world and how to see the world, or you'll see him touching things on the side as he walks. Olfactory, like scent, like smell, like one of his favorite scents is like when you do like onions and ginger, like really strong, like Asian flavor scents. And then vestibular is maintaining balance in the body, and he likes to like spin and climb and do all those things that have to do with vestibular. So here are some examples. Here's like balloons up in the, we'll start at the top left. There's some balloons and being on the trampoline. This is a bite to his hand, which he does a lot. And sometimes it's just out of sensory needs. He's also doing his finger right now, or he'll just like you say something to him and he's like, he's kind of excited and overstimulated. So he bites his finger, trying to look for that input. This is a kid that's climbed really, really high in a tree. Here on the bottom right is one of the times he wanted to go to Walmart, and then he sits up in the cart and then he pushed himself all the way back. That's how big he is, from the cart all the way to the bottom. And then the one on the top right is a little girl on her tippy toes, because a lot of kids with sensory processing tend to be on their tippy toes. So executive functioning is another deficit that comes along with autism, and you see this a lot with my stepbrother. And so if he was here, he would be able to tell you, all the top the top and bottom movies of 1942, but we're not sure if he took his medicine on time or if he set an alarm or if he ate. So it's all those things that we, in our working memory of things that we have to do in our schedule that we forget to do. So working memory, cognitive flexibility, of course, we know is an autism problem in general, where, we have a hard time, like, seeing this is something we do or don't talk to people, or, you can't climb on every couch or things like that. Problem solving. Again, Dominic is really smart and he's able to do a lot of things, but when it comes to problem solving, like, he just gets stumped. He doesn't know how to be like, okay, let's try this solution. Oh, wait, that didn't work. Let's try this one. Like, he just sits there. Like, he's just like, no idea how to proceed forward. Problems monitoring is, being observant of the environment. Is somebody engaged in the conversation with us socially? Am I safe? Things like that. Verbal reasoning. So being able to talk to somebody, let's say he was talked to by a police officer, and be able to just be like, hey, I have autism, sorry, be able to have any kind of verbal reasoning like that, or accept verbal reasoning from somebody else. Attention seeking behaviors, inhibitions, very unaware, no self-control. So, just like a toddler who doesn't understand, Austin will throw a tantrum in the middle of the store, doesn't care how loud he is, doesn't care who's there, doesn't care what's happening. It's all about him. So when preparing to do a task, they find it hard to organize their thoughts and actions in order to figure out what sequence of steps we need to do to get there. So that takes a lot of frontal lobe executive functioning. And then also, one of the things Temple Grandin said is that she can't hold a piece of information in her mind while she manipulates the next step in the sequence. So we have to be like writing it down or having the sequence. Everything has to be very sequenced and rote, and less dynamic. Another deficit is motor planning. So this is a skill that helps us to perform steps that we need to make movement happen. So we have to motor plan, like, I just scratched my back, like I got a motor plan how to do that, or raise my arms up, or like do these different things. So when we would ask him, he's definitely gotten better, but when you'd ask him, like, one he's been working on for a long time is pointing, and his speech therapist calls it full arm pointing. He'll do this one, right? But to be able to do that action is actually under motor planning. The video that I have right here is him trying to stick his tongue out. So asking him, if I ask you to stick your tongue out, you could stick it out, no problem. Here he is trying to work on that motor plan.
Head still. Lick. Let me see. Lick.
You hear him making the sound, but nothing is happening.
Let me see. Lick.
Oh, there we go.
There.
So when I put my finger out and he had something to focus on, he could do it, but just sticking his tongue out for no reason, he can't. So as many times as we model that big point, he'll go, this one, I want this one, over and over and over again. And he's like not getting, there's like some deficit in that, or like, come here, right? Or, hey, I need, something like that. Those take motor.
Head still.
Is there something else in there? Oh yeah. And they kind of seem to be clumsy. So he's not clumsy in the normal sense, but he will like drop things and like not carry enough, or not be able to like hold, like he doesn't like to carry his backpack. He has a hard time walking for a long time, like things like that, completing physical tasks. And how they work on that now in OT is they trying to get him to do multi-step processes. So I want you to, jump on the trampoline and then swing on the swing and then go down the roller coaster and then hand me the puzzle piece. And trying to get him to do that, be able to do that multiple times.
Lick.
Oh, handwriting. That was another one. So one of the things that happens with him with handwriting, in order to be able to have it, so he practiced writing it in boxes and getting the boxes to be smaller and all these things. But what he still will do is he will write letters on top of each other. And so this, in order for us, we don't even realize that when we write on a piece of paper, like you're taking notes right now, you have planning of the way it's going to go. He doesn't have that motor planning. So he'll write A and then a U on top of the A, and then an S, and then a TIN way over here. And so it's like, it's like he could write more legibly, but he just doesn't. So this is a really big part. And I had mentioned to Heather when we talked that, luckily, knock on wood, we haven't had to take Austin to like the ER or anything like that. But last year, he had dental work done a few years prior, and one of his crowns broke. It actually rotted from the inside out. And so it was half broken. And then the dentist we saw, we're like, well, I guess you just wait till it breaks. Well, then it came off one day at school. He had like blood on his shirt. And then a piece of the tooth was just stuck in his tooth. In his gums. And it wasn't going to come out. It wasn't loose because it was not an appropriate tooth to come out. And so I go, our dentist decided it wasn't an emergency, so they wouldn't see us. And then a local dentist I went to, and like they wouldn't help me. They saw him, but his aggression is so hard that they wouldn't really help us. And so they were like, you have a couple options. You can call this surgery center, like he needs to be put under, or you can go to CHOC, which is our local children's hospital, and go to the ER, and hopefully they have a pediatric dentist that they can call. So I was going to go to CHOC, and I was leaving there. I was so stressed. I was like, I don't know what to do. And we get into the CHOC parking lot. I was like, all right, maybe I'm just going to go to CHOC. Like, I don't know what else to do. We get into the CHOC parking lot, and he is screaming at the top of his lungs. It's like a parking structure. And like, now he is hungry. We have to walk in there. I'm trying to ask them, how long is the ER wait? They don't know. Do they have a dentist? They can't tell me. You got to get there, blah, blah, blah. So we get there, he's screaming at the top of his lungs, he's hungry. I'm like, this is just not going to work, because if we have to wait a long time, it's going to be horrible, right? So I ended up deciding to leave, and then we had to like find another dentist who could get us in with an anesthesiologist. But then, our insurance decides that anesthesiology is not necessary. And so all the process that they use for dental is most places that I talk to, they do ketamine and then do an IV. The first time he got it done, they were able to use the gas, and it was so much better. He sat on my lap, they used the gas, he passed right out, picked him up, put him on the table. When he woke up in my lap, but apparently they don't do that anymore. And so I found this place, they said they didn't use ketamine. And then like 2 days before, they were like, we do use ketamine. So he's sitting on my lap, they give him a shot, and he just goes like, it's like really creepy. And then they have to pick him up and bring him to the back, do the IV, do all the dental work. So, for families, like, it's like hard to try to get medical attention because of the aggression. So this was just the other morning. He has, as I call him, high cognition, but also high behaviors. And these are his behaviors. So what he's doing is he's hitting himself in the head. And usually the slapping of the head is linked with more of his inflammation. But it's really sad. It's really hard to watch. He can't communicate his needs. He doesn't feel good. He has aggression towards others and self. And this is a very real part of autism. And it's very hard to bring this version of him out into the world, even if it was under a really big need, because it's hard for people to see and understand. And for me to keep him busy in somewhere like the ER. Working in the autism with autism in the therapy room, I have a couple of different clients. I have one client who came to me at 17 with multiple mental health diagnosis. She also had anorexia. She had a lot of things going on. And after spending about 4 or 5 sessions with her, I said, I think you have autism. And come to find out all the backgrounds, such as hating different clothes, jeans, her mom fighting with her to wear tights to ballet and it being a screaming match all the time, her head banging. And when I talked to the parents, they were like, oh yeah, I remember that someone mentioned autism. And I was like, yeah, she's one that ended up in the hospital, she hadn't gone to the bathroom in about like 2 weeks. So they had to do she had to drink this whole drink, and they had to do like a clear out for her. And now she's the one that has SIBO. And I also have some families with, trying to figure out getting services with younger kids. We try to work on treating comorbidities as far as OCD, ADHD, and how we can kind of cope and manage those. Social skills is a lot of that I talk about. One of my other ones, she's a really beautiful artist. So I really try to join with her and look at her art and talk to her about it. And then we also have had multiple times where, she's asked me, is that weird? Should I do that? What do you think about this? Is that okay? So teaching social skills and managing how to be an adult. I've been talking to my brother for years that you have autism, but you still have to function in society and be a normal, healthy, typical person. So traditional treatments, this is Austin's old speech therapist. So right after you get diagnosed by a neurologist, usually an ABA company is assigned to you and they just start calling. I don't even know how that happens. And they come do a functional behavioral assessment. They want you to do a lot of hours. ABA is one of those things that, in my opinion, needs a revamp. Austin, for example, they've really hammered in how old he was. So if you ask him right now, how old are you? He says, I'm 6, because that's what they focused on. And if you try to ask him safety questions that they worked on, such as my name or phone number, he also gets very mad and yells and doesn't answer. So, if you found Austin rogue in the wild, he's not going to answer what his mom's name is or phone number. So those are the things, some of the reasons we decided that we needed to take a break from ABA, which was 2.5 years ago. He's been in speech consistently since he was 2. But social skills, he tried that for a while. He wasn't really ready. We had him in OT, and then our insurance wouldn't pay for it, so we had to find a new provider. Physical therapy, he's never had to do, but some kids do, special education class, and then some kids and parents do individual or family therapy because it's a lot to cope with a lot of grief. The type of speech therapy that Austin is in right now is called Gestalt language processing. And this is kind of a newer movement in speech therapy. And it's where kids learn speech in phrases and then break down, slowly learning the meaning of the individual word, where typically developing brains are going to learn word by word, and then what that means, and then how I put that together. And so you take a phrase he's already doing. So I am climbing. Would be his phrase. So then she would prompt him to say things like, I am climbing high, I am climbing up high, and then I am climbing way up high, or I am climbing on the blue playground, or, and adding little things to the phrases. So it helped us get out of the rote language of, I want pizza, I want this, so now he can kind of say some different phrases, and he's coming up with new phrases and breaking up some of his things. So one of his ones we're working on right now is that when he's leaving somebody, he will say, bye, I love you. And it's sweet and all, except for when he's talking to the bus driver, right? That's a little odd. So we want to break that phrase, and we want him to go bye, see you next week, or bye, have a good day, or something different that breaks up that pattern of behavior. Here's a little sample. So his speech therapist, this was early on in their speech therapy. He's been working with her for almost 3 years now. And she's working on play in the kitchen. And so what she did was she wrote 4 steps of what he needs to do in the kitchen, and then he's trying to follow them.
Yeah. Number 3, stir food.
So she's modeling with him and showing him how to stir.
Number 4,
This is basically how to play.
eat food. Here, let's go eat it. Eat food. Uh-oh. Eat. Scoop.
So these various little play things like scoop and do, and so she's helping him kind of learn to do that. So this has been really helpful for us. And the school districts in a lot of places are unaware of Gestalt language processing, but it's going to be an amazing tool once it gets more baseline. Oh, perfect. Okay, 10 minutes left. All right. These are some other treatments that we're doing with him. We've done blood work, we've done urine tests, hair metal tests. He takes a bunch of different supplements. Here he is in a detox bath. We've done an EEG, we've done homeopathic detoxes. Right now we're doing SLIT, which is called sublingual immunotherapy, and LDI, which is low dose immunotherapy. And then we are doing, or then another option is HBOT, which is hyperbaric oxygen therapy. these are the food sensitivity tests that we did, and he was sensitive to all these foods. So we had to pull them out and give him drops, which is sublingual. That's where the slit comes in. And here he is getting an EEG. And on this side, this is his hair metals test. And the very top one is aluminum, which was 16 times higher in his case. So that's what we were detoxing from. Okay, that's it. I could say more about that, but I just want to make sure if there's any questions, we can talk about them. Sorry if I went a little bit over my time. Okay. So I think just in general, like clinical implications, I think that in the hospital setting, I would say focusing number one on sensory issues. So if the lights are too loud, if the sounds are too loud, my son likes a lot of input, squeezes and tickles and things like that. And that makes people really easily connected with him. And some kids that don't like that. The iPad is really important to them, and how can we have that, being accommodating to the parents coming in, and asking a lot of questions of what their child like needs and wants and likes, and yeah. I was just waiting. Is there any questions or? No, good. How are the schools currently caring for children's autism? Caring in what way? So they follow the legalities. We do the IEP. All the kids that have the IEP, they pretty much follow it. You get, how are they meeting the needs? It depends on the child. So for us, he has a temporary aid that I was saying. He has a lot of accommodations. He doesn't have to wear his shoes. They give him extra time on the playground. They let him climb high. He can have snacks whenever he wants. They have his favorite puzzles. They have one of the things, at least in our district, they have multiple different types of seating. They have a rocking chair. They have a ball chair. They have just a regular, kids plastic chair. The kids sit at big tables. They have a visual schedule is really big. Yeah, I don't know how all school districts are, but I would say ours are fairly good at that. Yeah, the flexible seating is really big. I've seen some teachers, put those in like GoFundMe type thing. You guys are so welcome. Thank you for giving me the opportunity. I loved that so much, and I hope you have an awesome rest of your day. Take care.